Sorry. Do we have time for just a couple minutes of questions? Okay, great. Questions from the audience? Or are you all prepared to move forward and do your own business case? Yes,
And
ma'am.
Lucy's answering all the questions, by the way.
Yes, I had a question related back to the cost and your cost benefit. One of the things that I noticed was missing, you can identify early on people who are at risk for diabetes, but getting health behavior change without looking at, so you're assuming that, it seemed to me that you were assuming that if the providers knew and they took an intervention, that you were going to get a change in the benefit. And if, without having the patient, person, family caregiver, whoever it is, engaged, and without looking at your profile of how many of this and how many of that and how many of the other, you really can't look at your cost benefit because you have a whole other team that's not at the table. So I'm just wondering how you put that in.
So basically, the question is around the issues of would you run a sort of distribution analysis of which patients were in which groups and missing costs associated with how do you actually enact behavior change that's outside of the clinical experience and involves the patients and family members. Is that correct?
And then also, would you add, say, for example, motivational interviewing to this so that you know if you hit resistance and what stage of change they're in?
Absolutely. Absolutely. What I presented was not, the case is huge, so I presented snippets of that case, but absolutely, those are essential elements of what would go into the business case.
Yeah, and I can just comment, at Intermountain Healthcare, this is obviously a topic we've been working on for a number of years, and we've sort of developed the training in two different kinds of ways. One is for those people who are pre-diabetic, and those people who've already been diagnosed with diabetes, because the issues around behavior change are so very different. And it's a very tough area because a lot of the really negative complications of the disease happen decades later. And, you know, for most people, you know, I want to know, will I get better tomorrow? And if they can't see that there's going to be an impact in 30 years from now where I won't go blind or won't need an amputation, it's hard to motivate people on things that are very, very difficult. But I think the notion of involving family members and informal caregivers in our community is really crucial and key, as well as community representatives. You know, if you think about the churches, if you think about the natural places that people congregate and how those entities can be influential and at no cost to the business case.
And from a business case perspective, those elements would be identified in the requirements, in the how we're going about doing that. And they would be costed out in terms of providing those kinds of services.
Great. Other
The reason
questions?
I wanted to highlight it is because I think in all of the continuing professional development, if we don't really look at not having it unidirectional just from educating providers without really understanding the other side of the care, the engagement, you know, how is it that we begin to do that rather than making it a one-way street? It's just a question.
That's an excellent point. Other questions or clarifications? Yes, sir.
Thank you for the presentation. You know, once you made the decision to launch your plan, what is the process you go through in terms of looking at outcomes and maintenance? In other words, you know, there are always issues that come up that you might have anticipated and those that are not anticipated. So once the project is up and running, is that a part of the business plan as well, or is that just a separate thing that you think about?
That's typically not part of the business plan. The business case really sets the stage for approval of a project. It's a go, no-go decision, or it's a go with modifications decision, and what have you. Once that has approved, then it moves on to a project manager. And what you're talking about would be part of what a project manager will have to plan for, right? But any changes to whatever is described in the project will have implications in terms of the scope of the project, in terms of the cost of the project, and in terms of the time to completion. And it has to be considered very carefully. But a project manager would be in charge of doing that.
Great. Other questions, clarifications?
There's just one thing that I wanted to mention, if there are no questions, that these costs and benefits are over a period of time. And they're typically over a period of 5 years, even though you can see cases that are a shorter duration business case or a longer duration business case. In the diabetes example, the duration was a 10-year plan, because if you think about diabetes intervention and you're looking at amputations and you're looking at end-stage renal disease, that takes some time to manifest. The benefits of that take some time to manifest. They're not immediate. But typically, when we're talking about a business case, we're looking at a 5-year horizon, and we're looking at costs and benefits over a 5-year horizon.
Yeah. The other point I'd like to just clarify, and I think that Elena made an important point about looking at the different stakeholders' perspectives and what are the benefits and the costs associated with those. But when you're making the business case and you're looking for that go, no-go decision, it's whose perspective are you delivering the business case for? And so especially in healthcare, if you're looking at savings to society, well, I work in a delivery system, and, we're not sort of in the business, if you will, of savings to society. It's how's it going to affect the bottom line for my particular organization, and do I have the funds and the fiduciary responsibility to deliver those funds on that? So whether or not it's a societal gain, whether or not it's directly to the delivery system, or whether it's to employers in many cases, especially when you're talking about the costs like pre-diabetes and diabetes care. So I think it's really important to think about how are you delivering that information and from whose perspective, even though costs and benefits will align to various stakeholders.
That's a great point that Lucy made. And from a business perspective, it's a funding agency. We're always developing a business case for a funding agency, right? Whoever is funding the project is the perspective that we're taking.
Mm-hmm. Yes, ma'am.
I may have missed this, but under the will they come, don't you think it's important that there's a needs assessment of the community that you're trying to reach? Because different community have different needs, particularly if you're attempting to look at type 2 diabetes, like are there food deserts? I mean, it gets a little complicated, but it would seem to me that early input on what different communities need would be pretty vital to the success of a program.
So this is the question about the needs assessment?
Right. And that would come early on. It would come under the how, because the how involves stakeholders, interviewing stakeholders to see what their needs might be and what might work in that community.
And what's the preferred way to deliver the information to them?
Mm-hmm.
Other questions or comments? Yes, sir.
Malcolm Cox. So my question is really about the capacity or the availability of expertise to do these business cases.
Mm-hmm.
One of the great problems with health professionals is they think they can do everything. And so I wonder if you could comment on the internal and external expertise that is needed to do this. In other words, to talk a little bit about, well, how do you get from here to there in developing a business case? Because I think the principles you've outlined are sort of standard and sort of readily explainable.
That's right.
But actually doing it, I think, is a very different thing. And where most organizations fall down is not securing the expertise, either internally or externally, to do a decent business case.
You want to take it, Lucy?
I certainly can. One of the things that I think is really critically important, this is not just a financial decision. And one of the ways in which I move forward in doing business cases, especially when I want them to be successful, is to use a team-based approach so that you have everybody with the fundamental knowledge necessary. So I am not a clinician, I'm an MBA, PhD, so I'm absolutely certain that I include clinical people on those teams. I've been working for over 30 years and doing participatory work, so I always engage representatives of the community. So, it's in vogue in healthcare to call them PFACs, or patient and family advocacy committees. And so we include patients and caregivers on those teams to really look at the entire business case, as well as important community partners. Because when you think about cost, the extent to which you can identify partners that are already doing some of this work, it becomes very important. So for example, in our pre-diabetes work, we've partnered with the food bank and we've partnered with the farmers market, so that we can provide discounted coupons to people to have access to fresh fruits and vegetables that they wouldn't necessarily be able to afford independently. And that was at no cost to the organization, because they were willing to step forward as an independent organization. So I think when you can think about a team-based approach, the finances are not, the sort of business case calculation is not that difficult. We're adding and subtracting in many cases. And then you also want sort of a researcher who can help you with the needs assessment that was talked about. You can help do a literature review, as Elena talked about, to understand what do we already know. And so that team-based approach is really what's needed. And I would say, think about how you harvest that from different sectors of your own organization in doing it, rather than thinking there's going to be one person who has all the knowledge. I don't think Elena would say that, if she was going to do one in diabetes, she would do that independently either. So we need everybody with the fundamental knowledge that's necessary to make the best business case possible.
The other thing that I would add to what Lucy said is that a person with expertise in business analysis is important in pulling these pieces together. It's critical to have all the stakeholders involved and to gather the requirements from all of these stakeholders. But there'll be conflicting requirements, there'll be disagreements. People may not know how to do this, and they may not know what is important to bring to the table. And therefore, having someone who can facilitate this process becomes very, very important. And this expertise can be hired from the outside to have someone to pull all of these pieces together to develop the business case. And it's not that that person is providing the content, but that person facilitates the process for gathering the content and identifying the various people who are really critical to be involved.
Other questions or comments? Yes, ma'am.
I was wondering about the assumption when you're talking about the funders, is that people can now change insurance yearly. And so the investment in the organization to come up with this disease management plan, and then people rotating off and going, somebody else may see the benefit besides the patient.
That's exactly right. And one of the challenges, so the business case was talking about challenges that they were facing. And one of the things that they were talking about is that on average, these members of the HMO rotate every 2 years. And therefore, they're funding a program and they're not really seeing the benefits of that program. And that's absolutely right. And then that's a tough decision to make. And the bottom line for that particular business case was that the benefits to the HMO were really marginal, but the benefits to the patients were really significant.
Yeah. I would also just comment on that for two reasons. One, I was in North Carolina for 21 years, when we had 23 health plans operating in the state. And even though there was a turnover of 1.5 years for people on average into a single plan, and a lot of these sequelae are, 20, 30 years out, everybody could agree, well, it's my patient today, but it's going to be your patient tomorrow. And so we were able to get a collective of health plans that would come together because they realized they were caring for a population. And in the United States, with the changing payment structures, with accountable care organizations and delivery systems moving into population health, this is the contextual factor of the marketplace that's really key and understanding. So I know at Intermountain Healthcare, we've moved to risk-based payment. And so the idea of preventing people from coming into the emergency room, from coming into the hospital, is now a financial benefit when it used to be a cost to the organization because of the perversities in the payment structure in the United States. So I think you have to think about that context.
Absolutely.
Thank you all.
Thank you.